Good evening. Thank you everybody for joining us. This presentation tonight is going to discuss minimally invasive surgery for the bunion, as well as specific product development by CrossRoads for the treatment of this bunion deformity via the minimally invasive surgery. Please feel free to include any questions through the chat box. Be happy to answer them at the end of the presentation. So we all know that a bunion is hallux abductovalgus and appears like this clinically and radiographically, and we all have many patients with these deformities. It's a very common deformity and a common procedure that we perform as foot and ankle surgeons. If you've followed some of the things in the literature that I've contributed, you'll know that I'm big with angles and millimeters and measurements, and so I just share with you this article, which took me approximately 12 years to put together, but I finally published it, which includes all these kind of normal angles of the foot and ankle, which you got to know what normal is to correct your deformity. So there's mild, moderate, and severe bunions. The typical bunions that we're discussing for the MIS procedures are the mild and moderate, kind of less than, the 14 or degree angle, or underneath the 14-degree IM angle. So important to learn, where you need to create your osteotomy. These are called the Osteotomy Rules, and I'm going to take you through these 3 rules, which are very important to understand kind of why we do what we do and how we do the procedure affects, of course, your overall deformity correction and alignment. So Osteotomy Rule 1 is where you have your apex of deformity, or we call it CORA, center of rotation angulation, which is where the blue and red lines intersect. If you cut the bone at that level, you're doing Osteotomy Rule 1. You can do an opening wedge at the top, you see that on your screen, or on the bottom, a closing wedge, or you can do part opening, part closing. So this is Osteotomy Rule 1. It lines up the red line and the blue line. Let's take an example. Here's a typical hallux valgus deformity, and we found that our CORA, or apex of the deformity, center rotation angulation, is at the Liz Frank joint, and we want to correct the red line to the yellow line. We do that via Lapidus procedure, and that basically corrects your deformity. Osteotomy Rule 1, not only is the apex or CORA at the Liz Frank joint, but also your osteotomy realignment is the Lapidus fusion at that level. Osteotomy Rule 1 is a good rule. Rule 2 is also a good rule, but what happens if you can't cut the bone at the CORA, or the apex? You have to cut it at a different location, and that's shown here. You can do opening wedge, closing wedge, or neutral wedge. And so this is sometimes necessary, and we can see that example in the hallux valgus deformity, where our CORA, or apex, is more in the midfoot region, and we cut the bone distal to the CORA, just as I showed in that Osteotomy Rule 2 example, and you have to translate the osteotomy lateral, in this case, the metatarsal neck osteotomy, in order to line up the red line on the yellow line. And although you're cutting away from the CORA, you're translating, and the amount of translation is the distance at the level of the osteotomy between the yellow and red line. So that shows that you have to translate, maybe in this case, 6 millimeters, 7 millimeters, something in that nature. And you do see a hang off about 6 millimeters or so lateral on that capital fragment. So that's Osteotomy Rule 2. Osteotomy is away from the CORA, and you can get it aligned that way. Osteotomy Rule 3 is the unwanted rule, and that's where you identified the CORA correctly. You decided that you had to make an osteotomy away from the CORA, or the center rotation, which is fine, but you didn't rotate around the CORA. You rotated around your osteotomy, or you made your deformity correction about the osteotomy, not about the CORA or the apex. And this creates a secondary translation where the red line and blue line are parallel, but they're not lined up over top of each other. And what does this look like? Well, here's an example of a base wedge osteotomy. I'm not saying base wedge is not a good procedure, but in this case, the osteotomy was made distal to the cora. The cora is at the, or apex at the Lisfranc joint, but the osteotomy is distal. So you have to translate, as I mentioned before. How much do you translate? It's at the level of the osteotomy between, the millimeters between the yellow and blue, or yellow and red line. And so if you angulate, but don't translate, as we did in this case with the opening wedge plate here, then your yellow line and red line are parallel, but they're not collinear or overlapping. And that creates a secondary translation. You can see that this patient still has some hallux valgus deformity because the first ray is far medial to the second ray or second metatarsal. And so therefore, not only we corrected the IM angle, but we created a secondary widening between the first and second metatarsals, and that's an unwanted rule called Osteotomy Rule 3. So I think it's very important to look at the bunions critically like this, objectively, so you can see what your osteotomy or fusion or realignment surgeries affecting the foot. So this is a study that I did with one of my fellows where we looked at kind of before and after surgery, how much translation do you want? The question is, do you translate 50% of the capital fragment, 33%? How much do you translate? Well, you should translate to correct a deformity. And so what we showed here is that, say, for example, the red line, if you look, is how much peaking of the fibular sesamoid. So in the pre-op X-ray, maybe there's 5 millimeters peaking of the sesamoid. Post-op, how much of the peaking of the sesamoid is there. And the goal would be if you see preoperatively 5 millimeters of sesamoid peaking, maybe you just need to shift the metatarsal head with your osteotomy 5 millimeters. And so we did a study where we took a bunch of patients and measured preoperative or intraoperatively how much translation that I performed, and my fellow measured how much preoperative translation would be required based on that description that I just mentioned. And so this study basically did show that we could accurately realign the sesamoids by lateralizing the capital fragment the necessary amount. So translation is important, and it can be preoperatively predicted, and shouldn't we be more accurate than just kind of shifting it till it looks good kind of thing is the concept there. Also, frontal plane rotation is important, and with a osteotomy that I'm going to show you, the transverse osteotomy of the metatarsal, if you do a distal transverse osteotomy, you can rotate the capital fragment and correct your sesamoid position that way with derotating plus your translation. So this is a powerful osteotomy. So real quick, what's our complications with distal osteotomies? We can get recurrence of deformity because you did the bump and run, so to speak. You can get delayed unions, non-unions because of the open nature of the traditional bunion surgery. You can get limited range of motion, which is the big thing that kind of pushed me over the fence to try to do more of the minimally invasive bunion procedures, is because, there are some patients that you get a great cosmetic result, but postoperatively they just get stiff. And so now you converted them from hallux valgus to a hallux limitus type of condition, and they just don't get better with therapy, and they're not very happy. And this limited function creates a painful situation and a patient that's not happy. And this, I think, was occurring with me, 1 out of 10 patients, or maybe sometimes 2 out of 10 patients with this stiffness. Avascular necrosis can happen because of open procedure of the capital fragment. Not common, but can happen with the traditional bunion procedure or bunionectomy. And then you can get incisional neuritis based on, closure or scarring or so forth with the bigger open incision. Minimally invasive hallux valgus surgery. There's been many authors. It's been around for quite a while as far as the MIS kind of technique for this bunion correction. And this is the typical approach where the MIS procedure was done via cutting the bone, shifting the bone, either with a burr or a saw or something. And then it was just pinned, relatively stable, not ultimately stable, pinned. And the capsule was kind of shish kebab with the pin, and the pin was external. And this was a 4 to 6 week recovery, but when they took every step postoperatively, it would move the pin would get, draining and could create some pain, swelling issues because it's unstable, and also the pin is prominent. So there's even been reports of osteomyelitis after this kind of pinning procedure. Bosch and colleagues had done many of these procedures and had good results and with the pinning procedure, and published studies that showed comparable results to the traditional procedure and no AVN. And you can see that it is a big translation, but you see the healing of the bone here on the x-ray on the right, that the bone does heal, even though it's quite a bit of translation, even more than 100% here, almost 99% translation. So this is what it looks like clinically, the traditional kind of Bosch technique, small little incision, pin out the end of the toe. Can get infected, can be painful. The traditional MIS bunion surgery can use like a burr type procedure for bone osteotomy, or a saw, or you can use multiple drill hole osteotomy is typically what I use. So this paper was published in 2016, where we talked about doing the procedure without the wire, and just to show you the technique where it's a small little incision, you do multiple drill holes. So this is kind of a Lazaroff coracotomy type technique of bone cutting, more low energy osteotomy, less thermal injury to the bone. So multiple drill holes where you drill through the metatarsal neck, then you do your osteotomy through an osteotome, and you complete the osteotomy, and you can then use a separate incision for screw placement, and that allowed for stability without the wire being external. So that really helped with correction. And also doing some soft tissue rebalancing through percutaneous incision was also done. So this modified technique basically allowed for internal fixation, which is more rigid fixation, and also some soft tissue balancing procedures with a few incisions, small little incisions medially. So there are complications with this minimally invasive procedure. You can get lateral x-ray deviation issues. I would say that in general, when you're doing traditional bunion surgery, you're not used to taking many lateral x-rays because you're doing an Austin or Chevron, or you're just sliding it lateral and you're not so worried on the lateral x-ray malposition. But in this case, the capital fragment can shift and you need to be very mindful of the positioning. There are other companies that have these procedures and so forth, but it's really kind of, screws and burrs and such, not really a systematic approach to how this can be done. Again, these are other implants that are available, but the MINIBunion system is intended for fixation of osteotomies, correction of hallux valgus procedures, and there are risks that can happen with the use of these devices, allergic to the implant, fracture, soft tissue complications, infections, prolonged healing, revision surgery, similar to all other type of implants. This is the device. It's the MINIBunion. It has two fixation points. Basically, there's one fixation point for the proximal segment of the metatarsal, which is non-locking. There's a locking distal segment for the capital fragment. So there's basically each screw holds each side of the osteotomy. And then what's also innovative is this soft tissue anchoring hole through the plate. So you can actually reef the capsule to the plate to correct the soft tissue imbalance of the hallux during this surgery as well. So again, it gives you more stability and gives you that soft tissue option. So what's the technique for this mini bunion implant? How do I do this? Well, it's a 1.6 millimeter wire that we use to drill across the neck of the first metatarsal. This is done under fluoroscopy, and that ensures your level of your osteotomy. Then you put on this guide which tells you whether it's a long or short implant, meaning the intermedullary portion. You want to know, you don't want too long of an implant that goes deep and would invade the Lisfranc joint. You want to make sure you have the right depth. So this guide on the medial side of the foot has 2 notches to determine whether it's a short or long implant that you put in. Again, the traditional incision versus the minimally invasive incision, typically it's 10 to 20 millimeters in length, depending on the patient. So with this wire, you insert it, and then there's a special guide. Again, the real advantage of this technique is not only is it kind of step-by-step and guides you through it, but gives you the intraoperative tools or instruments to provide, accurate correction. And that's something I think lacking in a lot of other systems and not really out there. So this first guide allows you to do multiple drill holes. You can see all the drill holes here. So you could create multiple drill holes at the neck level and then do your osteotomy with an osteotome. With this second guide you see on the right-hand side of the screen. So you can either insert an osteotome or a saw through that guide. So basically, if you can put 1.6 wire in, orthogonal to the long axis of the metatarsal, as I showed on the fluoroscopy exam, then you can, accurately put your osteotomy at the right level. So basically the guide puts you there, you do your saw cut or your multiple drill hole and your osteotomy with an osteotome, depending on your preference. And this is what the guide looks like. There's kind of 2 anchoring pins on either side of the guide, and then you can either run, this is a wire through the middle to do multiple drill holes, or you can run your saw through there if you decide to do an osteotomy with the saw. This is an osteotomy with the osteotome after multiple drill holes, or you could use the saw. Once the osteotomy is cut, then you implant the device. It has a handle that you hold on to, that you actually slide it in the medullary canal. Pretty straightforward. As you push the head lateral, the canal opens up and you just slide this implant in there. It has, again, the handle which you can do that with. And then that really sets your translation because you can pick your width of the implant. So remember I mentioned that you can pick the length of the implant. You can also pick the width. So remember I mentioned the study that my fellow and I worked on, that if you want a wider implant, we have that available to push or translate the capital fragment more lateral. So that is available. There's a 3.5 millimeter and a 4.5 millimeter options for that. Here you see a little Houston passer. This is for the suture after we fixate the bone with the screws. So first what you want to do is lock the implant. Once it's in the canal, you want to lock it to the proximal metatarsal segment. So this oblique non-locking screw allows you to do that. You can see that placed here. And then what I do is so that sets the capital fragment translation, but you want to make sure you get your angulation correct and your rotation. Your angulation typically is not not needed to be adjusted because it's a flat cut and it sits flat and it doesn't angle on you. But sometimes with larger bunions, larger shift, it may want to angle medial or lateral, and you have to look at that. And then you can get your rotation. Either you rotate or hold the hallux to get your derotation and put the screw in. Sometimes I use a temporary wire to hold 1 and 2 together, so I get my rotation and a temp wire and then add the screw. There's a couple different options on that end, but once you have this proximal oblique screw in, that really holds your position, so you can put your capital fragment screw in. Here's just an example of sliding in the implant. You can see checking and confirming on the AP X-ray that I'm in the canal, and then sliding it up the canal to the level of the neck of the implant, which is at the level of your osteotomy. Here you can see kind of clinically how it looks. We're sliding it in and then pushing it in further. Frontal rotation is nice. Once you have your proximal insertion, you can rotate. I use this temporary wire to rotate your frontal plane. So just like with Lapidus procedures, you can rotate frontally. With this procedure, since it's transverse, you can do rotation as well to realign your sesamoids in the crista plantarly. Once you get your 2 screws placed, you have your osseous realignment. Now you can do your medial capsular repair, or maybe you do a percutaneous ladder release. Most times I use a 64 beaver blade laterally to release the capsule. And then if I feel like I need to reef the medial capsule, I use this technique where I kind of use a large needle and a vicryl stitch to kind of come out distally through the incision and through a small stab incision distally, and basically grab that medial capsule, and then I will pull it with the Houston passer through the plate and then tie it to complete your soft tissue repair. You can see that done here, kind of through the incision out distal, and then through the incision distal back proximal, basically kind of like a percutaneous Achilles repair type of concept. And then this is held to the plate so you can get it well anchored, because as you know, usually the capsule proximally is not very stout to be able to close that to correct that transverse plane soft tissue. So immediately weight bearing, I do in a surgical shoe. Of course, the first week they're kind of guarded weight bearing, but I let them full weight bear with the surgical shoe. See them in a week, and then usually let them shower at that time. And then 4 to 6 weeks in the post-op shoe, weight bearing is tolerated. Sometimes 4 weeks, sometimes up to 6 weeks, depending on the swelling and the patient. And then back to regular shoes in that 4 to 6 weeks, kind of like normal shoes, like a sneaker type or loafer type, because they will have some swelling still. And then 8 to 12 weeks back into normal heels or dress shoes or activities as they want. So this is usually a pretty quick, we call it active recovery, meaning, you know, they're recovering, but they can be very active during this time. So this is very low risk for AVN, no bump removal. But I would say sometimes I do have the long-standing bunions that do have some significant medial bump that I have to, you know, plane or resect, or maybe lengthen the incision a bit to accomplish that, to cosmetically make sure that the patient's going to be happy. It is reduction in post-op pain because it's such a small incision, less edema, less scarring. They can weight bear immediately post-op, and this is a strong implant, very strong, which limits the post-op swelling versus the old just single pin construct. You don't necessarily need a tourniquet. You can use one if you want. You can get frontal plane rotation correction. Usually it's under 20-minute surgical time, and this can vary as you get, you know, more and more experience with kind of the more minimally invasive procedures. And there's no significant range of motion reduction, which is key. And again, I think if you look at the literature, it's prominent with the patients are happy because it's basically not hurting them anymore, and they can do functionally what they want to do. those are the two big things, and that's what this is really shown to do. And again, function is key for these patients, as well as reduction in pain. So here's just a pre-post-op example of this correction, and this is a pretty significant correction. You can see the amount of translation that was required, and the concern is, of course, the bone. This is, again, you can see, 2 months after surgery, you don't see a lot of bone in that interval laterally. But again, you don't open that part of the the soft tissues. So what you see is that the periosteum is stretched laterally, and it fills in all that whole area between the lateral-most aspect of the capital fragment distally and the shaft of the metatarsal, which I'll share with you some examples in a moment on that. Again, you can get frontal plane rotation, which is really key for this, and really allows you to get those sesamoids where you want, versus the traditional chevron. And you can see some of the percutaneous incisions here, that lateral release percutaneous incision, the medial incision for the insertion. You can see that I use dissolvable sutures here, which is what you see 3 weeks post-op. This is a patient, and they don't hurt when you range of motion their toe or they go up on their toes. It doesn't hurt because you didn't really invade the joint at all. It's all extra articular. Just going to share with you a video here with kind of post-op, 3.5 weeks post-op, showing that she's able to move the toe, and I'm able to push it up and down. You can see that the callus was debrided planarly from the bunion, and that distal crease was from the capsular reefing, which basically kind of tightens up that medial skin. And so here's a patient 2.5 months post-operatively. You can see she's well healed, not much for an incision, so she's real pleased. She's back to her kind of healed, little wedge healed pretty shoes or boots, and she's extremely happy. You see here the amount of consolidation that's occurred at 2.5 months. I know it's not, the x-ray is not greatest quality, but you can see how much bone formed into that lateral area where I mentioned that we stretch the periosteum, but we don't really injure the periosteum laterally. So here's another example of kind of a 3-month post-op x-ray where I went a little bit more proximal with the osteotomy, so I wouldn't have to translate as much, and I could still get pretty good correction with this osteotomy, or this level of the osteotomy as well. So this implant's very stable, very versatile for kind of various options. So what do we have with the MINIBunion? We have something of great importance with this, minimally invasive kind of trend in foot and ankle surgery. It's very cosmetic. It does not affect the function negatively. It's extra articular. It is a step-by-step systematic approach, which allows for kind of that accurate realignment and kind of patient-specific implants based on sizing and accurate objective realignment. It is based on this preoperative planning method that I mentioned. You can really plan out how much translation you need. There is ability for soft tissue rebalancing, which I think is one of the big keys to maintaining good bunion correction long term. Like I said, various size options are critical, so it can be patient-specific. Low-energy osteotomy, which means faster healing. You can use the osteotome, or if you so choose, the saw is just as effective and heals just as well. Stable locking fixation is really key because you don't have that relative stability with just a wire. It's compared to the Lapidus, you're not having non-union issues, which is a concern with the Lapidus no matter what method you use, and but it is for more larger bunions. And then everything's in a kit, and it comes in a kit to your surgical suite, and you can mail back parts of the kit, which is a real benefit of the MINIBunion system. It's eco-smart, and the hospital gets reimbursed money back for kind of recycling and sending materials back. Thank you for your time, and I appreciate your attention this evening to the MINIBunion project. If anybody has any questions, I'm happy to answer them regarding this technique or the actual implant. It is something that is out there now and commercially available for maybe the past 6 months. I have had patients with 6-month results doing very well, and maybe in future webinars I can share with you some of those results, both objectively and subjectively from patient questionnaires. I think one question I tried to answer is people were concerned, surgeons are concerned about, is the bone going to heal because it's a lot of translation, and hopefully given the x-rays I showed you, you could be confident that it will heal, although it is definitely a bit of leap of faith at first because you're not seeing that, month after surgery, callus formation or that assurance where you can say, okay, it's time to get out of the surgical shoe and back into your sneaker or loafer, that sort of thing. So you have to be confident in the method and your ability to kind of not be overly aggressive with your dissection and technique. So the question came in about translation. The level of the osteotomy, since I showed that one x-ray that I went more proximal, would you have to translate less if you went more proximal? And yes, that is true. As you go more proximal towards the cora or the apex, you don't need to laterally translate as far if your osteotomy level is closer to the Lisfranc joint rather than further down by the head of the first metatarsal. The issue with that is that the bone becomes narrower, meaning the diameter of the bone. So yes, you can translate it, but the osteotomy tends to be sometimes more unstable, meaning it can angulate plantarly or dorsally a little bit easier, like I showed in those previous examples. So you just have to be a little bit more mindful of that. But it is still as effective, and I've used that technique with some of the larger, more mild, not mild, but more moderate bunions to gain more correction through the more distal procedure. The only issue is you get into the diaphysis, and that's bone that's harder to heal, meaning it may take more time for healing and may lead to a little bit longer course of surgical shoe or longer course of some postoperative swelling till that bone does fully consolidate. Yeah, so the question was, what is the cost of the, the surgical kit? Basically, either to a surgical center, or I know some of the foot and ankle surgeons are doing these like in an office setting or office surgical suite, basically. That's something that I would contact the representative locally from CrossRoads so they can work with you. I know that they're basically a company that wants to work with each surgeon to make sure that they have the proper equipment, and it does depend cost-wise whether you're in a hospital, surgery center, or in your office. It definitely is comparable to other products out there, but you have to, like I said, look into it to see if it fits your needs on the pricing end of things. And then the other question was, how do you know about the translation of the capital fragment as far as putting it in the desired position? So that's a really good question. This implant allows a lot of versatility in translation, and I've been very impressed with it because there's two ways to translate. One is what I mentioned, where you can have, say, a 3.5 thickness implant, intramedullary, mini-bunion implant, 3.5 or 4.5 millimeters. So if you think about the cortex medially is about, say, 2 millimeters thick, and then you add the translation of the thickness of the implant, which is 3.5 millimeters. And if you add those two together, the thickness of the medial wall of the bone or cortex is 2 millimeters. Add the 3.5 millimeters, then you're translating, 5.5 millimeters total translation of the capital fragment. So that's how you can figure how much translation you're getting there. The other way to induce further translation, which I've done, is you can tighten that oblique screw that's in the proximal segment. And as you tighten that oblique screw, not only does it compress your osteotomy, but it also creates some more additive lateral translation of the capital fragment. So there's two ways to induce that translation. So that was a great question. And that brings me to another point I didn't mention. There are times that I do resect with oscillating saw or a rongeur the medial eminence that remains on the proximal portion of the metatarsal. So there is a kind of step off on the medial side where you did the bone cut of the osteotomy on the proximal piece, and that can be shaven down so it's not medially prominent right along the medial aspect where the insertion of the mini-bunion plate and screws are. So you can resect that shelf proximal, and that typically is something where it can be done through the same incision. You don't really have to lengthen the incision to get that piece out. So that's very important aspect as well, so that you can keep the cosmetic nature of it. There was another question that I'm getting here, happy to answer. How often do you add an Aiken osteotomy with this technique? I think that, again, Aiken osteotomies are something that may be needed to correct, your hallux interphalangeus, so to speak. I think that Aikens are done maybe a bit more than they should be, in my opinion. If you have a true osseous deformity, then that's, of course, when you add the Aiken. But I think with the advent of getting the right translation laterally with this technique, utilizing your lateral soft tissue release and your medial soft tissue tightening, your balancing of the soft tissue, I don't find it as common to do the Aiken osteotomy. There is, of course, patients that require that, or you think that that adds to the correction of deformity, and I do employ the Aiken osteotomy, and I think it's definitely something to use on the right occasion. But I think with this technique, utilizing both the bone accurate correction and the soft tissue balancing correction, I think it's a lot less commonly needed. I think that's all the questions I have for tonight, Lisa.